Welcome to our review of Diabetes Management Program. This program is designed to provide you with the knowledge on how to effectively manage patients with diabetes as they are admitted to the long-term care setting. Today's topic includes the review of American Diabetes Association's Standards of Care in Diabetes, which includes the current clinical practice recommendations and is intended to provide the components of diabetes care, general treatment goals and guidelines, and tools to evaluate quality of care. Diabetes mellitus is a highly prevalent health condition in the aging population. Over 1/4 of people over the age of 65 years have diabetes, and 1/2 of older adults have prediabetes. The number of older adults living with these conditions is expected to increase rapidly in the coming decades. So let's begin learning. In today's agenda, we will be reviewing Understanding Diabetes, Overview, Types, and Common Challenges in Elderly Residents, Monitoring, Blood Glucose Monitoring, and Targets for Treatment, followed by discussion on management and treatment, which will include medication, management presentation, and lifestyle changes. The presentation will also discuss and look at common acute and chronic complications related to the disease. And finally, we will include the discussions in the next upcoming slides, the standards of care and best practices and guidelines for diabetes management. By the end of the topic, we will be able to learn to work together to enhance our diabetes management practices and improve the quality of life for our residents. This program is designed to enhance your knowledge and skills, ensuring that our residents receive the highest standards of care. Learn the standards of care for diabetes management in a nursing home setting, gain practical skills in monitoring blood glucose and administering medications, be equipped to prevent and manage diabetes-related complications, and improve documentation practices and communication within the healthcare team. Remember that a successful medical evaluation depends on beneficial interactions between the person with diabetes and the care team. Diabetes mellitus is a group of metabolic disorders of carbohydrate metabolism, in which glucose is both underutilized as an energy source and overproduced due to inappropriate gluconeogenesis and glycogenolysis, resulting in hyperglycemia. There are 4 principles that is recommended for review when dealing with patients with diabetes. So let's quickly review this information before proceeding to diabetes management. First, review of diabetes and population health. Diabetes and population health recommendations emphasize the importance of timely, evidence-based treatment decisions made collaboratively with patients and their care partners, considering social determinants of health and individual factors. Diabetes management should align with the chronic care model, focusing on person-centered team care, integrated long-term approaches, and ongoing communication and goal setting. Regular assessment of diabetes, healthcare maintenance, using reliable data metrics is crucial to improve care processes and health outcomes, taking into account care costs, individual preferences, and treatment burden. The American Diabetes Association highlights the importance of person-centered care to guide clinical decisions and improve outcomes. Second, status and demographics of diabetes care. The care of diabetes for all population faces ongoing challenges, particularly in achieving target levels for A1C, blood pressure, and LDL cholesterol. Recent data shows that a significant portion of U.S. adults with diabetes are not meeting these goals, with only 50.5% achieving A1C less than 7% and 47.7% achieving the blood pressure goal of blood pressure of less than 130 over 80 millimeters of mercury. Many individuals who fail to meet these targets are not receiving adequate pharmacotherapy. Certain groups, including young adults, ethnic minorities, and those facing financial or social hardships, are particularly disadvantaged in diabetes care. The Chronic Care Model, or CCM, aims to improve diabetes care through 6 core elements: proactive delivery system design, self-management support, evidence-based decision support, clinical information systems, community resources, and quality-oriented health systems. Effective diabetes management also necessitates reducing therapeutic inertia, leveraging telehealth to increase care access, and addressing financial barriers to medication adherence. Quality improvement efforts should focus on integrating traditional metrics with patient experience and cost assessments, promoting adherence to clinical guidelines, and utilizing data to evaluate health equity. A coordinated, systematic approach involving a diverse healthcare team and emphasizing person-centered care is essential for optimizing diabetes management and improving outcomes. Third, tailoring treatment for social context. Tailoring diabetes treatment to social contexts is crucial to addressing health inequities influenced by social determinants of health, or SDOH. Recommendations include assessing food and housing insecurity, financial barriers, and social support, with referrals to local resources. Health inequities related to diabetes are influenced by economic, environmental, and social conditions, resulting in greater risk and poorer outcomes. Lastly, social capital and community support. Social capital, which includes support from community and personal networks, is crucial for better health outcomes in individuals with diabetes, while the lack of social support leads to poorer outcomes. Factors like racism and discrimination, integral to social determinants of health, or SDOH, often remain unaddressed in routine care, but significantly impact self-care and medication adherence. The CCM highlights the importance of community resources and social support networks. Organizations like the American Medical Association and the Agency for Healthcare Research and Quality emphasize the need for practical applications of clinical recommendations through community linkages. Community health workers, or CHW, community paramedics, peer supporters, and lay leaders are vital in delivering diabetes self-management education and support services, especially in underserved communities. Diabetes is common. Approximately 37.3 million people in the United States have diabetes, which is about 11% of the population. Type 2 diabetes is the most common form, representing 90% to 95% of all diabetes cases. About 537 million adults across the world have diabetes. Experts predict this number will rise to 643 million by 2030 and 783 million by 2045. Diabetes is a condition that happens when your blood sugar, or otherwise known as glucose, is too high. It develops when your pancreas doesn't make enough insulin, or any at all, or when your body isn't responding to the effects of insulin properly. Diabetes affects people of all ages. Most forms of diabetes are chronic, lifelong, and all forms are manageable with medications and/or lifestyle changes. Symptoms of diabetes may include frequent urination, polyuria, excessive thirst, polydipsia, increased hunger, polyphagia, weight loss, fruity breath odor, tiredness, lack of interest and concentration, vomiting and stomach pain, often mistaken as the flu, a tingling sensation or numbness in the hands or feet, blurred vision. Frequent infections, slow-healing wounds, bedwetting in children and adults. Recognizing hyperglycemia and hypoglycemia signs can be easy, but sometimes it's hard to tell them apart because they have overlapping symptoms. Hyperglycemia can present with various symptoms, including confusion, headache, frequent and excessive urination, extreme thirst, dry mouth, blurry vision, weakness, shortness of breath, and nausea. Hypoglycemia can manifest with several symptoms due to the release of other body hormones, including confusion, headache, irritability, trouble concentrating, fatigue, hunger, sweating, shaking, and a fast heartbeat. And in severe cases of hypoglycemia, caused by too little glucose in the brain, can result in confusion, combativeness, disorientation, seizures, loss of consciousness, and even coma. What are the types of diabetes? There are several types of diabetes. The most common forms include, first, type 2 diabetes occurs when the body either doesn't produce enough insulin or the body's cells don't respond properly to insulin resistance. It is the most prevalent form of diabetes, primarily affecting adults, though children can also develop it. Second, prediabetes is the stage preceding type 2 diabetes, characterized by elevated blood glucose levels that are above normal but do not yet meet the criteria for a type 2 diabetes diagnosis. Third, type 1 diabetes is an autoimmune condition where the body's immune system targets and eliminates insulin-producing cells in the pancreas, though the exact cause is unclear. Approximately 10% of individuals with diabetes have type 1, which typically manifests in children and young adults, but can also onset at any stage of life. Fourth, gestational diabetes occurs in some individuals during pregnancy and typically resolves after childbirth. However, having gestational diabetes increases the risk of developing type 2 diabetes later in life. Fifth, type 3C diabetes arises when damage to the pancreas, excluding autoimmune causes, affects its insulin production. Conditions such as pancreatitis, pancreatic cancer, cystic fibrosis, and hemochromatosis can lead to this type of diabetes. Surgical removal of the pancreas, or pancreatectomy, also results in type 3C diabetes. Latent autoimmune diabetes in adults, or LADA, shares similarities with type 1 diabetes in that it stems from an autoimmune response, but it progresses more gradually than type 1. LADA typically affects individuals diagnosed at age 30 or older. Aside from this, there are also other types such as maturity-onset diabetes of the young, MODY, also known as monogenic diabetes, arises from inherited genetic mutations that impact insulin production and utilization in the body. There are currently more than 10 distinct types of MODY, affecting up to 5% of individuals with diabetes, often running in families. Another one we will not be discussed further is neonatal diabetes, which is a rare form of diabetes occurring in the first 6 months of life, also classified as monogenic diabetes. Approximately 50% of infants with neonatal diabetes have a lifelong form known as permanent neonatal diabetes. For the remaining cases, the condition resolves within months of onset, but may reappear later in life, referred to as transient neonatal diabetes mellitus. Type 1 diabetes symptoms often appear suddenly, prompting immediate blood sugar testing. Symptoms of other diabetes types and prediabetes develop gradually and may be less noticeable. To ensure timely diagnosis, the American Diabetes Association, ADA, recommends the following screening guidelines. First, individuals with a body mass index, BMI, over 25, 23 for Asian Americans. Regardless of age, if they have additional risk factors such as high blood pressure, abnormal cholesterol levels, inactive lifestyle, history of polycystic ovary syndrome or heart disease, or a close relative with diabetes. Second, individuals over 35 years old should have an initial blood sugar screening, with follow-up tests every 3 years if results are normal. Finally, women with a history of gestational diabetes should be screened for diabetes every 3 years. Individuals diagnosed with prediabetes should be tested annually. Individuals with HIV should undergo diabetes testing. Healthcare providers diagnose diabetes by checking your glucose level in a blood test. The A1C test, also known as a glycated hemoglobin test, measures your average blood sugar level over the past 2 to 3 months. It does not require fasting and determines the percentage of blood sugar attached to hemoglobin, the oxygen-carrying protein in red blood cells. Higher blood sugar levels result in more sugar-attached hemoglobin. An A1C level of 6.5% or higher on 2 separate tests indicates diabetes, while a level between 5.7% and 6.4% indicates prediabetes. Below 5.7% is considered normal. In a random blood sugar test, a blood sample is taken at any time, regardless of the last meal. A blood sugar level of 200 milligrams per deciliter, abbreviated as mg per dl, or 11.1 millimoles per liter, abbreviated as mmol per liter or higher, suggests diabetes. For a fasting blood sugar test, a blood sample is taken after an overnight fast. A fasting blood sugar level less than 100 milligrams per deciliter, 5.6 millimoles per liter, is normal. 100 to 125 milligrams per deciliter, 5.6 to 6.9 millimoles per liter, is considered prediabetes, and 126 milligrams per deciliter, 7 millimoles per liter, or higher on 2 separate tests, indicates diabetes. During a glucose tolerance test, you fast overnight and then have your fasting blood sugar level measured. After consuming a sugary liquid, blood sugar levels are tested periodically over the next 2 hours. A blood sugar level less than 140 milligrams per deciliter, 7.8 millimoles per liter, is normal. A level between 140 and 199 milligrams per deciliter, 7.8 to 11.0 millimoles per liter, indicates prediabetes, and a level over 200 milligrams per deciliter, 11.1 millimoles per liter, confirms diabetes. There's currently insufficient evidence to support the use of continuous glucose monitoring, CGM, for screening or diagnosing prediabetes or diabetes. However, in cases where hyperglycemia is not unequivocally evident, such as during a hyperglycemic crisis, diagnosing type 2 diabetes requires confirmatory testing. This confirmation can be achieved through a different test on the same day or the same test on a different day. Additionally, significant discrepancies between A1C and repeated blood glucose measurements should raise concerns about potential issues or interferences with either test. For diagnostic screening of diabetes, fasting plasma glucose, 2-hour plasma glucose during an oral glucose tolerance test, and A1C tests are appropriate. These tests reflect different aspects of glucose metabolism and thus may identify different groups of people. The 2-hour plasma glucose test typically diagnoses more people with prediabetes and diabetes compared to fasting, plasma glucose, and A1C cut points. Interventions for preventing type 2 diabetes have been shown to be effective mainly for those with impaired glucose tolerance, not for those with isolated impaired fasting glucose or prediabetes as defined by A1C criteria. Again, diagnosis of diabetes requires 2 abnormal screening test results, either at the same time or at different times, except in cases of clear clinical hyperglycemia symptoms or crisis. If using different times, the second test should be done promptly and can be a repeat of the first or a different one. Diabetes management is complex and personalized, involving several strategies tailored to each individual's needs. Diabetes treatment goals aim to prevent or delay complications and optimize quality of life. According to current ADA guidelines, individuals with T1D should be screened for celiac disease-associated autoantibodies at diagnosis and when symptoms arise. The ADA also recommends annual thyroid disease screening using serum TSH. These goals should be developed collaboratively with people with diabetes to honor their preferences and values. Type 1 diabetes is often linked with additional autoimmune diseases such as autoimmune thyroiditis, celiac disease, and Addison's disease, all of which involve the production of organ-specific autoantibodies. These autoantibodies can be used to screen individuals with T1D for related autoimmune conditions. While some individuals with these autoantibodies will develop clinical disease, the frequency and follow-up for screening patients with positive autoantibodies remain debated. Some experts advocate for regular screening, while others suggest screening only when clinical symptoms are present. Long-term exposure to a diabetic environment leads to changes in bone metabolism and impaired bone microarchitecture through a variety of mechanisms on molecular and structural levels. These changes predispose the bone to an increased fracture risk and impaired osseous healing. In a clinical practice, adequate control of diabetes mellitus is essential for preventing detrimental effects on bone health. Currently, there is no conclusive model explaining the mechanism of action of diabetes mellitus on bone health, particularly in view of progenitor cells. Recent studies indicate that the increased fracture risk in diabetes cannot be solely attributed to changes in bone mineral density, BMD, or confounding factors like the risk of falls. Instead, the diabetic environment primarily affects the biomechanical properties of bones by deteriorating their organic composition and bone material strength. This occurs either directly through altered cross-link formation or indirectly by changing cellular activity in osteoblasts and bone progenitor cells. Diabetic conditions reduce the mesenchymal stem cell, MSC, population and viability, exacerbated by increased bone marrow fat in obese individuals with type 2 diabetes. This fat releases cytokines and free fatty acids, promoting chronic inflammation and inhibiting osteoblastic activity, ultimately affecting bone strength and increasing susceptibility to microdamage, fragility fractures, and impaired fracture healing. Maintaining bone health is essential for overall well-being, as osteoporosis, a condition where bones become weak and less dense, increases the risk of fractures from minor incidents. Early diagnosis and management can help protect bone health and reduce fracture risk. Both type 1 and type 2 diabetes negatively impact bone quality, though they affect bone density differently. Type 1 diabetes, an autoimmune condition typically developing in childhood, reduces peak bone mass and increases the risk of hip fractures later in life. Type 2 diabetes, often associated with obesity, increases fracture risk due to insulin resistance and the duration of the disease. Higher blood glucose levels and diabetes-related complications like nerve damage and hypoglycemic episodes further elevate fracture risk. Key risk factors for osteoporosis include personal or family history of fractures, smoking, excessive alcohol use, inadequate calcium and vitamin D intake, lack of exercise, and age over 70, among others. Nutrition therapy for individuals with diabetes is designed to foster healthful eating patterns centered around nutrient-dense foods in proper portions, aiming to enhance overall health and achieve specific objectives. These include supporting individuals in managing and maintaining healthy body weight, thereby improving overall health outcomes. Additionally, nutrition plans are tailored to help meet personalized goals for glycemic control, blood pressure management, and lipid levels. By emphasizing these targets, nutrition therapy aims to delay or prevent complications associated with diabetes, thereby supporting long-term health and well-being. A personalized nutrition approach takes into careful consideration a variety of factors that shape an individual's dietary habits and needs. This includes respecting personal and cultural preferences, assessing health literacy levels, ensuring access to nutritious foods, and evaluating readiness for making behavioral changes. By integrating these elements into the design of nutrition plans, practitioners can create strategies that are more likely to be embraced and sustained by the individual, promoting improved health outcomes over the long term. Holistic eating patterns complement this personalized approach by emphasizing the development of healthy eating habits rather than fixating solely on specific nutrients or individual foods. This broader perspective encourages a balanced and varied diet that supports overall health and well-being. By focusing on holistic eating patterns, nutrition plans aim to enhance nutritional quality, optimize health outcomes, and promote sustained dietary adherence. Weight management strategies for individuals with type 1 or type 2 diabetes, as well as those with prediabetes and overweight or obesity, emphasize personalized eating plans designed to create an energy deficit, complemented by increased physical activity and ongoing behavioral support. In prediabetes, achieving a weight loss of 5–7% or more is recommended to mitigate the risk of progressing to type 2 diabetes. For individuals at risk of type 2 diabetes, medication-assisted weight loss, alongside encouragement of healthy lifestyle behaviors, can facilitate a 7–10% reduction in weight. Even those with prediabetes at a healthy weight should engage in behavioral interventions, including regular aerobic and resistance exercises, to establish lifelong healthy eating habits. Healthcare professionals, particularly registered dietitian nutritionists, RDNs, play a pivotal role in delivering effective support for these interventions. For many individuals with type 2 diabetes and overweight or obesity, achieving a 5% weight loss is crucial for improving glycemic control, lipid profiles, and blood pressure. However, more aggressive weight loss goals, such as 15%, may be considered based on individual circumstances, feasibility, and safety. Although sustaining long-term weight loss remains challenging, emerging medications beyond metabolic surgery show potential in maintaining weight reduction and improving cardiovascular outcomes beyond the 10–15% threshold. Food insecurity and accessibility are critical issues that healthcare settings must address proactively through routine screening to identify individuals lacking consistent access to nutritious foods. In personalized nutrition care, eating patterns and meal planning strategies are fundamental. Eating patterns like the Mediterranean diet or DASH, dietary approaches to stop hypertension, provide structured frameworks emphasizing specific food choices known to support health, backed by extensive research demonstrating benefits for conditions like diabetes and cardiovascular disease. Meal plans offer practical guidance tailored to individual preferences, cultural considerations, and health objectives, dictating when, what, and how much to eat. Dietary approaches such as carbohydrate counting or the plate method provide effective tools for managing specific dietary needs, including glycemic control in diabetes management. Integrating these strategies into nutrition care allows healthcare providers to tailor interventions effectively, addressing diverse patient needs while promoting health outcomes and dietary adherence. For individuals with diabetes observing religious fasts, culturally sensitive guidance and education are crucial to effectively manage risks such as hypoglycemia and dehydration. Carbohydrate intake management is pivotal in diabetes care, although optimal levels remain inconclusive. Monitoring carbohydrate intake is crucial for achieving glucose goals in type 1 and type 2 diabetes. Low carbohydrate and very low carbohydrate diets have shown promise in reducing A1C and decreasing the need for anti-hyperglycemic medications in type 2 diabetes, particularly in the short term. However, Long-term effectiveness and cardiovascular implications of these eating patterns are still debated. Emphasizing high-quality, nutrient-dense carbohydrates rich in fiber from sources like vegetables, legumes, fruits, dairy, and whole grains is recommended to optimize health outcomes. Dietary fiber intake is associated with lower mortality and reduced risk of type 2 diabetes. It's crucial to minimize refined carbohydrates, sugar-sweetened beverages, and processed foods, which displace healthier choices. Protein intake recommendations for individuals with diabetes remain nuanced and personalized, reflecting varying effects on health outcomes. While specific benefits of altering daily protein intake for optimizing glycemic control or cardiovascular risk are inconclusive, individualized approaches based on existing dietary patterns are advised. Some studies suggest that moderately higher protein diets, 20–30% of total calories, can enhance satiety and aid in managing type 2 diabetes effectively. Importantly, recent evidence indicates that strict protein restriction is unnecessary for individuals with diabetic kidney disease, DKD, as it does not significantly alter glycemic or cardiovascular parameters and may increase the risk of malnutrition. Plant-based proteins, which are lower in saturated fat and beneficial for overall health, have shown promise in reducing mortality risks, particularly when replacing animal proteins. These insights underscore the importance of tailoring protein intake to individual needs and preferences within the broader context of diabetes, management, and dietary health strategies. For individuals with or at risk for diabetes, there is no universally recommended percentage of calories from fat, emphasizing the need for personalized macronutrient distribution based on individual eating patterns, preferences, and metabolic goals. Focus should be on the type rather than the total amount of fats consumed to optimize metabolic health and reduce cardiovascular risk, with a particular recommendation to limit saturated fats. Research supports the beneficial effects of a Mediterranean eating pattern on glycemic control and lipid profiles in people with type 2 diabetes, characterized by high intake of fresh fruits, vegetables, whole grains, legumes, nuts, seeds, and olive oil, and moderate consumption of fish, eggs, and poultry, while minimizing sugars, processed foods, and saturated fats. Diabetes technology encompasses the hardware, devices, and software that assist individuals with diabetes in self-management, including lifestyle modifications, glucose monitoring, and therapy adjustments. Traditionally, this technology has been categorized into insulin delivery methods, syringe, pen, patch devices, or pump continuous subcutaneous insulin infusion, CSII, and glucose monitoring systems, blood glucose monitoring, BGM, or continuous glucose monitoring, CGM. The scope of diabetes technology now also includes automated insulin delivery, AID systems, connected insulin pens, and diabetes self-management support software functioning as medical devices. When admitting a resident to long-term care who uses an insulin pump, automated insulin delivery system, continuous glucose monitoring, CGM system, or glucose support software, it is essential to have a physician's order. This order should specify the insulin dosage and the frequency of glucose monitoring and recording to ensure coordinated care and prevent the risk of overdosing through manual glucose monitoring methods. Continuous glucose data from the CGM should be recorded, particularly if the resident refuses fingerstick tests. Additionally, insulin pump delivery must be documented in the medication administration records. For residents capable of independently managing their glucose monitoring system and insulin pump, a self-management assessment should be obtained and documented. This approach is crucial in a nursing home setting to ensure the proper and safe management of diabetes care. Older adults with diabetes are at a higher risk of hypoglycemia than younger adults. Thus, hypoglycemic episodes should be monitored and managed routinely. For older adults with type 1 diabetes, continuous glucose monitoring, CGM, is recommended to reduce hypoglycemia. For those with type 2 diabetes on multiple daily insulin doses, CGM should be considered to improve glycemic outcomes and decrease glucose variability. Automated insulin delivery systems and other advanced insulin delivery devices, such as connected pens, are recommended for older adults with type 1 diabetes to reduce hypoglycemia risk based on individual abilities. In 2017, the American Diabetes Association updated their standards of care and hypoglycemia definitions. Hypoglycemia definitions vary per individual, but blood glucose levels less than 70 milligrams per deciliter are considered an alert for hypoglycemia, prompting corrective action. A glucose level less than 54 milligrams per deciliter is deemed clinically significant and unequivocally hypoglycemic. Severe hypoglycemia is not assigned a specific biochemical value. It is defined as a low glucose level causing cognitive impairment, requiring another person's assistance to administer carbohydrates or glucagon for recovery. This table lists the ADA's definitions of hypoglycemia levels. The following are the classification of hypoglycemia. 1. Level 1 hypoglycemia is recognized as the threshold for neuroendocrine responses to falling glucose levels in people without diabetes. Therefore, it is recommended that physicians' orders for hypoglycemic protocol in long-term care starts when blood sugar are found below 70 milligrams per deciliter. 2. Level 2 hypoglycemia, defined as blood glucose less than 54 milligram per deciliter, 3.0 millimoles per liter, is the threshold at which neuroglycopenic symptoms occur and requires immediate action. 3. Level 3 hypoglycemia is characterized by severe events with altered mental and/or physical functioning, requiring assistance from another person for recovery. When a patient's blood glucose level drops below 70 milligram per deciliter, immediate treatment of hypoglycemia is crucial to prevent the condition from worsening. The signs and symptoms of hypoglycemia can vary based on the severity of the event and differ between patients. These symptoms are generally categorized as autonomic or neuroglycopenic. Autonomic symptoms include both adrenergic, catecholamine-mediated, and cholinergic, acetylcholine-mediated symptoms. Adrenergic symptoms, such as tremor, palpitations, tachycardia, and anxiety, are mediated by catecholamines. Cholinergic symptoms, such as sweating, hunger, and paresthesias, are mediated by acetylcholine. Patients taking beta-adrenergic blockers may not exhibit adrenergic symptoms, so it is crucial to counsel them on recognizing cholinergic and neuroglycopenic symptoms. The blood glucose threshold at which hypoglycemic symptoms occur varies based on an individual's diabetes management. For patients with consistently elevated blood glucose levels, the threshold for hypoglycemia is higher. Conversely, those who frequently experience hypoglycemia have a lower threshold. Neuroglycopenic symptoms resulting from a lack of glucose in the central nervous system may include dizziness, weakness, drowsiness, delirium, confusion, seizures, and potentially coma. In the long-term care setting, unlike hospitals, healthcare professionals are not required to evaluate patients daily. Federal guidelines mandate assessments at least every 30 days for the first 90 days after admission and at least once every 60 days thereafter. While patients may be seen more frequently in practice, there is a risk of uncontrolled glucose levels or significant fluctuations without timely practitioner notification. Healthcare professionals can adjust treatment plans via telephone, fax, or in person at long-term care facilities if they receive timely alerts about blood glucose management issues. Nurses can consider looking at ADA's standard of practice to determine if goals of treatment are met using reasonable A1C goals, fasting and preprandial glucose and bedtime glucose monitoring for all types of patients admitted in the long-term care setting. These include healthy with few chronic illnesses with intact cognitive and functional status, complex and intermediate with multiple coexisting illnesses accompanied by 2 or more activities of daily living impairment, and those that are very complex with poor health. The following alert strategy could be implemented. Immediate notification. Contact a healthcare professional immediately. If blood glucose levels fall below 70 milligram per deciliter, 3.9 millimole per liter, treatment of hypoglycemia should not be delayed. Also, contact a healthcare professional if 2 or more blood glucose values exceed 250 milligram per deciliter within a 24-hour period, especially if there is a significant change in status. Prompt notification. Contact as soon as possible if glucose values are between 70-100 milligram per deciliter, 3.9-5.6 millimole per liter, as the treatment plan may need adjustment. Glucose values consistently exceed 250 milligram per deciliter, at 13.9 millimole per liter, within a 24-hour period. Glucose values consistently exceed 300 milligram per deciliter, 16.7 millimole per liter, over 2 consecutive days. Any reading is too high for the glucose monitoring device. The person is sick, experiencing vomiting, symptomatic hyperglycemia, or poor oral intake. The preferred treatment for hypoglycemia in conscious patients is glucose, but any readily available carbohydrate source that contains glucose can be used. The rule of 15 should guide this treatment process. This rule helps ensure the proper resolution of hypoglycemia and prevents overtreatment, which can cause rebound hyperglycemia. It is important to avoid carbohydrate sources high in protein, as protein can delay carbohydrate absorption and the resolution of hypoglycemia. Providing patients with examples of carbohydrate sources that contain approximately 15 grams of carbohydrate can be beneficial. These examples include glucose tablets or gel, carbohydrate content may vary, 5 or 6 Lifesavers candies, 4 ounces of regular juice or soda, not diet, and 8 ounces of skim milk. This practical approach ensures that patients have a clear understanding of how to manage hypoglycemic events effectively. Remember that to use this approach for alert patients. Several organizations, including the American Society of Consultant Pharmacists, ASCP, American Diabetes Association, and the Endocrine Society, have jointly issued guidelines on glucagon administration for severe hypoglycemia. They recommend prescribing glucagon to individuals at risk of level 2 or level 3 hypoglycemia episodes. Glucagon, a hormone that raises blood glucose levels, can be administered via nasal spray or injection, particularly beneficial when a person with severe hypoglycemia is unconscious and unable to ingest food to raise their blood sugar levels. Given its cost and storage considerations, healthcare providers are advised to ensure glucagon is readily available when needed, with specific dosing typically set at 1 milligram via intramuscular or intravenous injection, followed by glucose monitoring every 15 minutes, and immediate physician notification in emergent situations. There are different types or classes of medications that work in different ways to lower blood glucose, also known as blood sugar levels. Metformin, Glucopage, is classified as a biguanide medication and is the only available medication in this class. Metformin lowers blood glucose levels, primarily by decreasing the amount of glucose produced by the liver. Metformin also helps lower blood glucose levels by making muscle tissue more sensitive to insulin, so blood glucose can be used for energy. It is usually taken 2 times a day. A side effect of metformin may be diarrhea, but this is improved when the drug is taken with food. DPP-4 inhibitors help improve A1C without causing hypoglycemia. They work by preventing the breakdown of naturally occurring hormones in the body, GLP-1 and GIP. These hormones reduce blood glucose levels in the body, but they are broken down very quickly, so it does not work well when injected as a drug itself. By interfering in the process that breaks down GLP-1 and GIP, DPP-4 inhibitors allow these hormones to remain active in the body longer, lowering blood glucose levels only when they are elevated. DPP-4 inhibitors do not cause weight gain and are usually very well tolerated. There are 4 DPP-4 inhibitors currently on the market in the US: alogliptin, Nesina, linagliptin, Tradjenta, saxagliptin, Onglyza, sitagliptin, Januvia. GLP-1 and GIP are natural hormones in the body that help maintain glucose levels. Use of GLP-1 and dual GLP-1 and GIP receptor agonists is another strategy to help use these hormones to improve blood glucose management in people with type 2 diabetes. These medications have similar effects to the GLP-1 and GIP produced in the body, but are resistant to being broken down by the DPP-4 enzyme. These medications can result in large benefits on lowering blood glucose and body weight. Some agents in this class have also been shown to prevent heart disease. Most of these medications are injected, with the exception of one that is taken by mouth once daily, called semaglutide Rybelsus. Injectable GLP-1 receptor agonists currently on the market include dulaglutide, Trulicity, Exenatide, Byetta, exenatide extended release, Bydureon, liraglutide, Victoza, lixisenatide, Adalimumab, injectable semaglutide, Ozempic. One dual GLP-1 combined GIP receptor agonist is currently on the market called tirzepatide, Mounjaro. How often to inject these medications varies from twice daily to once weekly, depending on the medication. The most common side effect with these medications is nausea and vomiting, which is more common when starting or increasing the dose. Glucose in the bloodstream is processed by the kidneys, where it can either be excreted in the urine or reabsorbed into the blood. Sodium glucose cotransporter 2, SGLT2, in the kidneys facilitates glucose reabsorption. A new class of medications, SGLT2 inhibitors, blocks this action, leading to the elimination of excess glucose through urine. By increasing glucose excretion, these medications help improve blood glucose levels, promote weight loss, and slightly lower blood pressure. SGLT2 inhibitors, such as bexagliflozin, Brenzavvy, canagliflozin, Invokana, dapagliflozin, Farxiga, and empagliflozin, Jardiance, have been approved by the Food and Drug Administration, FDA, to treat type 2 diabetes. They're also known to improve outcomes for individuals with heart disease, kidney disease, and heart failure. Due to these benefits, SGLT2 inhibitors are often prescribed for people with type 2 diabetes who have heart or kidney conditions. However, because these medications increase glucose levels in the urine, the most common side effects include genital yeast infections. Sulfonylureas have been used since the 1950s to stimulate the pancreas's beta cells to release more insulin. The three main sulfonylurea drugs used today are glimepiride, Amaryl, glipizide, Glucotrol, and Glucotrol XL, and gleburide, Micronase, Glinase, and Diabeta. These medications are typically taken 1 to 2 times a day before meals. While all sulfonylureas have similar effects on blood glucose levels, they differ in their side effects, dosing frequency, and interactions with other drugs. The most common side effects of sulfonylureas include low blood glucose, hypoglycemia, and weight gain. Rosiglitazone, Avandia, and pioglitazone, Actos, belong to a class of medications called tiazolidines, TZDs. These drugs enhance insulin sensitivity in muscle and fat tissues and reduce glucose production in the liver. One advantage of TZDs is their ability to lower blood glucose levels without a significant risk of causing hypoglycemia. However, both drugs in this class can increase the risk of heart failure in some individuals and may also lead to fluid retention, edema, in the legs and feet. The goals of insulin therapy are to maintain blood sugar levels within a target range, thereby preventing serious complications associated with diabetes. Insulin is typically administered via injections. Using syringes or pen-like devices, insulin is injected into the fat just beneath the skin multiple times daily, depending on individual diabetes management needs. Insulin pump. This device delivers steady basal doses of rapid-acting insulin throughout the day, mimicking long-acting insulin, with additional boluses for meals to mimic rapid-acting insulin spikes. The pump administers insulin through a thin tube placed under the skin. Inhaled insulin, Afresa. Rapid-acting insulin delivered through inhalation at the start of each meal, bypassing the need for injections. Not suitable for smokers or individuals with certain lung conditions like asthma or COPD. For individuals with type 1 diabetes, insulin therapy is essential to compensate for the body's inability to produce insulin naturally. In type 2 diabetes, insulin therapy may become necessary when lifestyle changes and other treatments fail to adequately control blood sugar levels. Different types of insulin therapy include long-acting, ultra-long-acting, or intermediate-acting insulins. These types of insulin prevent blood sugar levels from rising when not eating. For instance, intermediate-acting insulin lasts approximately 12 to 18 hours. Long-acting insulin works up to 24 hours, and ultra-long-acting insulin can last 36 hours or more. Examples include Glargine, Lantus, Basaglar, Dedamir, Levemir, Degludec, Tresiba, and NPH, Humulin N, Novolin N. Rapid-acting or short-acting. Insulins. These are used before meals to manage glucose spikes effectively. They start working much faster than long-acting or intermediate-acting insulins, typically within 5 to 15 minutes for rapid-acting insulins. Rapid-acting insulin lasts about 2 to 3 hours, while short-acting insulin lasts about 3 to 6 hours. Examples include ultra-fast-acting Aspart, Fiasp, Lispro, Liumjev, rapid-acting Aspart, Novolog, Glulicine, Apidra, and Lacepro, Humalog, Admelog. Pre-mixed insulin. This combines 2 types of insulin into one preparation, suitable for individuals who find managing multiple insulins challenging. Premixed insulin can start working within 5 to 60 minutes and last from 10 to 16 hours. Insulin is administered into the subcutaneous layer of fatty tissue beneath the skin. It should not be injected into muscle or directly into the bloodstream, as this alters its absorption rate and effectiveness. The speed at which insulin is absorbed varies based on the injection site. The abdomen absorbs insulin most rapidly and is the preferred site for most people. Injecting insulin into the abdomen, specifically at least 2 inches, 5.1 centimeters, away from the belly button, is considered optimal for absorption. Slower absorption occurs in the upper arms, buttocks, and thighs, which are also viable injection sites. Diabetes can lead to both acute and long-term complications, primarily stemming from prolonged high blood sugar levels. Acute diabetes, complications that can be life-threatening, include hyperosmolar hyperglycemic state, and so HHS, occurs in type 2 diabetes with very high blood sugar levels, causing severe dehydration and confusion, requiring immediate medical attention. Diabetes-related ketoacidosis, DKA, primarily affects type 1 diabetes or undiagnosed cases, leading to acidic blood due to insufficient insulin, with symptoms like labored breathing and loss of consciousness, needing urgent medical intervention. Severe hypoglycemia, dangerous drop in blood sugar levels, mainly in insulin-using individuals, causing symptoms such as seizures, requiring emergency glucagon or medical treatment. Long-term diabetes complications stem from prolonged high glucose levels that damages blood vessels and nerves, and this includes cardiovascular issues, including coronary artery disease, heart attack, stroke, and atherosclerosis. Nerve damage, neuropathy, leading to numbness, tingling, and pain. Nephropathy, potentially resulting in kidney failure necessitating dialysis or transplant. Retinopathy can lead to vision loss or blindness. Foot complications, including infections and risk of amputation. Sexual dysfunction due to nerve and blood vessel damage, such as erectile dysfunction or vaginal dryness. Gastroparesis, hearing loss, oral health issues, such as gum disease, are also possible complications of diabetes. Managing blood glucose levels effectively is crucial in preventing these complications. The growing older adult population, with its higher incidence of diabetes, is placing increasing demands on healthcare providers to address the unique needs of these patients. Clinicians, including physicians, mid-level practitioners, nurses, and dietitians, must develop and implement various strategies to overcome common nutritional, lifestyle, and self-management barriers faced by older adults. This demographic is also prone to underreporting common diabetes symptoms, leading to delays in diagnosis. Classic symptoms of diabetes, such as polyuria, polydipsia, and fatigue, may be overlooked or misinterpreted as typical signs of aging. Additionally, mild dehydration in elderly individuals may result from aging-related changes in thirst response, insufficient fluid intake, medications, or hyperglycemia. The American Diabetes Association, ADA, advocates for individualized treatment goals and recommends less intensive targets for older adults who have advanced diabetes complications or significant cognitive and physical impairments. While glycemic targets for younger adults aim to reduce future complications, research indicates that older adults are more susceptible to developing diabetes-related complications at a faster rate. Standard diabetes treatment plans, which include dietary restrictions, increased physical activity, and pharmaceutical interventions, may pose additional health risks for older adults. Issues such as hypoglycemia, unintended weight loss, and falls can lead to adverse health outcomes. Therefore, nutrition interventions for this population are particularly crucial as they can help prevent these risks with a low likelihood of causing further complications. In conclusion, addressing the unique challenges of diabetes management in older adults requires a tailored approach that considers their specific needs and potential risks. By fostering collaboration among healthcare providers and emphasizing individualized care plans, we can improve outcomes and enhance the quality of life for our aging population. Together, we can make a significant impact on the lives of those living with diabetes, ensuring they receive the compassionate and effective care they deserve. Thank you for your time and attention in learning the updates in diabetes management.